Vanderbilt traditionally has done decentralized discharge phone calls. And so this was really the first attempt to try to create a central standard for doing that. And so initially it got going with a pilot in our main hospital, Vanderbilt University Hospital. And we started with nurses just cold calling. Our team also has social work and pharmacy and case management. So through that, we knew we needed automation. There was no way to scale this to support an entire hospital with humans making phone calls and not leaving messages or not getting messages. And we really wanted to create a 24/7, 365 for 30 days after discharge. We're your team. If you need anything in our health system, you can come to us and we'll guide you. That's a pretty big ask in one hospital, let alone 7. So we did start with just the one. And through that, what we learned is we really had to create a structure to be experts in our own health system. And as we've all talked about, we don't always know what medical records does in their process, or billing, or finance. And then clinical teams, services vary in how they take call for patients with needs. And like you said, inpatient and ambulatory, they are connected whether they like it or not. There is a flow that has to happen there. So I think that was one of our big takeaways, was to scale this to our health system. How do you create that playbook and really dive into, if a patient calls you, where do you send them? And if they have a need, who addresses that need? So we really had to dig in and get to know our own health system and become experts on navigating it and knowing how our teams operate, which in an ever-changing health system can be really challenging. Yeah, definitely through the initial learnings of the phone call outreach. And we've all had this experience. You call somewhere and they say, oh, that's not our department, let me transfer you. And you get there, well, that's not our department, let me transfer you. And by the 5th transfer, you're irate, you're done, you're ready to be finished. And so that was the experience I did not want for our patients. If you're going to call me and take time out of your day to respond to this technology that we've put in place, I want to be able to answer your question and navigate you. And with that, if you invite that, that's what they expect. Otherwise, you're no better than some of the customer service numbers we call, where they reroute you or promise somebody's going to call you back. So I really think that's something that made our team stand out, was that commitment to, if you're going to call, our kind of general motto is, if we don't know the answer, we'll find out who does, and we'll take the ownership of getting back to you. Because as a brand, if you can't navigate your health system, how am I as a patient supposed to figure that out?
The biggest challenge that I think we're facing now is finding out that we really need to have more coverage. I'm not quite as ambitious enough to say 24/7 yet, but I just need extended hours. Like, give me some FTEs so that we can cover till like 9 or 10 o'clock, Monday through Friday, and skeleton crew on the weekends, like 10 to 6, so that we can address the things that are more timely concerns that would affect patients' outcomes and revisits and readmissions. So definitely lots of advantages to starting at 1 and really honing what you need versus starting wide with a big old net and going, oh, we have lots of areas we could improve on. Anecdotally, we all know if you do a good job with post-discharge transitioning care, if you're helping patients to transition home safely and closing these gaps, that you end up with patients who are happier, who have better health outcomes, who don't come back to the hospital for unnecessary readmissions or revisits. But it's hard to quantify that. And so we were finally able to, with this, compare cohorts. And we looked at engaged patients, so anybody who had 3 or more incoming text messages with us. Because our first one is, do we have the best number for you? Yeah. Next day, do you have any questions? Nope. That's not really a meaningful engagement. I'm glad you participated, but I don't want to count that as somebody that we helped or that we had a conversation with. So we looked at 3 or more incoming. We found that patients were happier, which we knew just from the text conversations where they said, oh my God, thank you so much. Like, I just was really worried. Is this normal? I'm still so tired. you're just in the hospital for a week. You're gonna be tired for a while. Is this normal? Is the question we get billions of times every day. So happier patients, great. That doesn't really help with buy-in a lot of times because you kind of have to show me the money thing. And so we were able to show that we had fewer readmissions, and comparing the cohorts, they were very similar as far as demographics. And the group that didn't come back actually were higher on the case mix index. So these were patients that were more sick that we were keeping from coming back if they didn't need to. And with revisits, if you can direct them, well, this is something you can address with your PCP. This is something you can wait and call the surgeon's office. This you need to go see in urgent care. No, you definitely need to come back to the ER right now, like for that. If you address it sooner, that means it can get treated, patients can go home and not wait to where they're having to get readmitted because now they're in worse states. So it was great to be able to have some statistically significant data. For the HCAHPS, we have 7 hospitals, and so there was as much as a 7.4 difference on individual domains at individual hospitals. Looking overall at the system, there was a 2.8% increase in their rating for overall rating of the hospitals. So it's definitely been something that has now gotten leadership's attention. When we were looking at this, we wanted to make it seem very personable. Not that patients look at their discharge packets, but in their additional information, it does say you'll get a text or a phone call. There is a live nurse behind it. And so we've really tweaked verbiage probably about a dozen times at this point and are trying to make it very obvious that there are people responding to you on the other side because it's a painful process to be like, if you have questions, please tell me more. Yes. Great. How can I help you? Medications. Please tell me more about your med questions. What can I help you with? And then they're like, oh, you're not AI. No, I am not AI. I just answered 5 things that were very specific to you. I promise I'm not AI. We found that your octogenarians love emojis. Who knew? We get patients that text pictures in. They have all sorts of emojis. We send back emojis. So it's very, very, very casual human touch.
Well, we definitely took a different approach, and we've talked a lot about conversational messaging, which Vanderbilt's general motto is making healthcare personal. So we did want to be personable and for people to know there were humans behind it, but this was really Vanderbilt's first foray into using texting for a clinical use case. We have it for appointment reminders and billing and surveys like others. But our questions are things like, do you have your medications? And so we weren't really sure, one, how our staff would respond to that, but then how patients would respond. And so we were trying to think through, what's the Pandora's box if we open this up to our own teams to just converse free form? And we were more conservative. We were a little hesitant because the technology was new, and Artera has been lovely to let us take their appointment system and retrofit it into this clinical use case. So we were really learning the system and the features. And so we were like, let's focus on technology first, because some of the issues we anticipated potentially were branding. In communication, you lose body language, tone of voice, inflection, there's language barriers. So we didn't really want to put our staff in that situation to have to make those decisions in the moment while they're learning this new technology interface that sits with them beside Epic and Teams and all the other things that they have open. We also had the privacy concerns because, as you said, we put out do you have med questions, yes or no? And we predominantly rely on phone communication with some exceptions, but we leverage the quick responses and really try to lock down that communication because patients will freeform. And even though we say 1 for yes, 2 for no, they'll write a whole book about their headache and their blood pressure and photos of areas of their body that I can't believe they texted in to a healthcare provider. And So that was a privacy concern too. It is not so much on our part, but the patients not understanding that they're coming in potentially through an unsecure channel. So we had that concern. We also had some safety concerns and quality about, we don't want some nurses to think, a cough can be really benign, but it can also be really emergent. So we don't want somebody making the decision of back and forth about talking in text and potentially having a chat open with somebody else and missing something clinically important. So we went with the more conservative approach of really locking down what our staff can send. We put that through patient education and translations to make sure that it all comes across professional. We definitely want to move toward conversational, but we've gotten a lot of learnings on how patients use the system as well as our own team.
Thank you, ladies.